So
You'd have to go to IT.
Right, but clearly I can't get to my speaker.
The stress is still there.
Yeah, it is.
Go.
Just so
Yeah, I'm gonna have
disconnect.
that. I know. He was having problems with the tenant.
Sorry,
And as we say, he is pretty-
This one.
yes.
local man.
Oh.
And he was renting from us. Anyway, I managed to get the job. And then I ran it out. I've done him that favour. So then to say, verified.
We fixed it.
One of them, yeah, I've done it. Yeah. And then I want. I didn't self-defense and I gave them top. So that's
Right, good morning, everybody, and welcome to the Health Overview Committee. Before we start, I need to inform you this meeting has been live streamed and recorded. Please note all remote participants are muted at the outset of the meeting. If you are only able to speak at the invitation of the chair, please raise your hand or virtual hand if you wish to speak, and then only unmute when invited to do so. You ready? Thank you. Right, item 1 on the agenda, apologies for absence.
Thank you, Chair. We've had apologies from Councillor Tracy Huffer and we've got Councillor Mary Davis substituting, and we've also had apologies from Councillor Edward Towers. I'm not sure if there's a substitute here for him.
Thank you. Anybody know anybody else? I haven't seen any other one. No, thank you very much indeed. Okay, item 2, disclosable interest. Anything to disclose, please do so now, or if it occurs during the meeting, please alert us. Anybody want to disclose anything? No? Thank you. Item 3, minutes of the meeting held on the 25th of November 2024. Have you all seen those minutes and do you agree with them? Yes, go ahead.
Thank you, Chair. In Mr. Kachane's presentation on suicide prevention strategy, the Shropshire suicide rate is reported at 12.8 per 100,000 in the 3 years 2023. These are ONS figures. Mr. Kachane suggested that the results were similar for Shropshire, when in fact that the national rate is 10.3 and Shropshire's rate is 12.8, which is 20% higher. So this is clearly not similar.
Not similar, no.
So I move that the minutes be amended.
Are we happy to do that?
I agree.
Thank you very much indeed. Okay. Can we arrange to do that? We will change the minutes accordingly.
Thank you,
so,
Chair.
because it is.
If it
It
is
is significantly
significantly higher.
Good. Thank you. Thank you, Benny. Apart from that one, is everybody else happy with that?
I'm slightly concerned about that because the minutes of the meeting are correct.
It's just the information.
The information is wrong, so maybe we have to put in somewhere that actually this information is incorrect, because he did say that
And was challenged.
and was challenged. So
Okay.
so
So the minutes are in fact correct, but the information that was given at that meeting is
it's
incorrect.
20% wrong. Yeah.
That's Rachel.
Thank you. I was just going to suggest that I apologize because I haven't got them in front of me. I just need to go and check because it may be that in terms of there being 20% difference, but it's statistical is the issue. So I agree that it would be helpful to flag the concerns raised by the committee, and I can just clarify the wording in terms of statistical and the ONS data, and that might be question and the conversation, but apologies, I haven't got that in front of me. I'm happy to take it away and understand the concerns of the committee around that, because I think we were saying it was important, but I think it might be in terms of statistical and the way that it's calculated, and that might be.
It was about a 2% difference.
20%.
20%. Yeah, no, but if you look at it was 10 point something to 12 point something, so it's around in the figures around 2% rather, which is a 20%. So actually, that statistically, that 2% is quite a lot in numbers, isn't it? So,
but I think it's to do with confidence intervals and calculations.
Yeah. Well, it's 10.3 national rate and 12.8 is Shropshire's rate. Now that is 20%. So 12.8 is over 20% higher than 12.8 is over 20% higher than 10.3. And it depends upon what confidence intervals you're looking at and what statistical analysis you're looking at. A 20% difference is a significant difference. And Shropshire is one of the highest in the country.
Sorry, I take that, but I'm happy to go in a little bit more detail because I think it's calculated nationally is the point I suppose I was trying to make in terms of, I understand the point you make, and we just need to be clear that we've said that that's using national statistical calculations, but locally it was, I understand the concerns that that's still.
I agree, Richard. So in effect, we've said the minutes are correct. It's just the content of what was said,
which was challenged, but not within the minutes.
We'll minute it now that we're going to challenge that comment to clarify exactly what it means and what the correct figure should be.
Thank you.
Happy with that?
Yes, I mean you understand the implication that there appeared to be a minimisation of the difference when it's very important.
Yeah. Okay. So we approve those minutes then, and we will query the validity of that comment. Thank you very much indeed. Item 4, topic of question time. We're going to do members' question time first because the member of the public has not arrived at the moment. So item 5 is members' question time. We've got 2 questions, one from Heather Kidd and one from Bernie Bentic. I presume we go ladies first, being polite. Heather Kidd, would you like to ask your question?
This
please?
question is Shropshire's emergency services are in crisis.
Heather, could you put your microphone on?
I'm sorry. I moved it carefully and then didn't use it. Shropshire's emergency services are in crisis, and on the 3rd of January 2025, SAF declared a critical incident, which is not the first. These do happen. Will the chair please ask SAF to report on each month, October, November and December, and additionally for every month future until government targets for urgent care are met? Number 1, the numbers of patients seen in the A&E departments in each category of acuity and the number admitted, numbers of patients with 1 hour plus delayed handover from ambulances and the total number of hours delayed handover, waiting times from arrival at A&E departments to ward admission, the numbers of patients in the main waiting area at the start of each main staff shift each day, morning and evening, the number of deaths in the emergency department, and separately the number of deaths of those admitted as emergencies in the age categories of under 18, 18 to 49, 50 to 64, 65 to 74, and 75 years of age plus. The numbers of patients being cared for in corridors, and separately the number in other temporary escalation spaces each main shift of the day, and the number and type of emergency operations delayed by 12 hours or more.
Thank you. Thank you. Do we have a response for those questions? I believe Sophie.
We have not as yet received a response to that particular question, but once it is received, it will be published.
Thank you. Are you happy with that? Yeah, good. So there's a lot there, isn't there? There is. Right. Question 2, Councillor Bernie Bentic. Would you like to ask your question, please?
Thank you, Chair. Nationally, there was a 4-fold increase in respiratory infections admissions in November 2024, and the numbers were still rising at the time of asking of the question. On Monday, 9th of December 2024, Health Minister Wes Streeting ordered the NHS to focus on urgent care, saying, "This winter, I want to see patient safety prioritised as we brace ourselves for the coming months. I'm asking trusts to focus on ambulance delays, handovers, and the longest A&E waits." Yet on the 3rd of January 2025, SAF declared another critical incident and restrictions were placed on visiting. On the 3rd and 4th of January 2025, respectively, I counted 9 and 8 ambulances parked outside the Royal Shrewsbury Hospital A&E department. Will SAF please advise, 1, what public health measures it has taken to separate those with infectious respiratory illness and infectious gastrointestinal illness from other patients? 2, has it implemented FFP3 grade face masks for all health workers, patients and visitors who visit clinical areas, particularly those locations with respiratory illness, and use 2R grade face masks for others who cannot tolerate FFP3 face masks, including those with respiratory illness themselves, in accordance with national policies, and those policies were given to South. 3, has it or will it reduce or stop elective operations in the 2 Shropshire acute hospitals until all urgent targets are met, and allocate staff from surgical and ward teams to care for urgent care patients, with supplementary training where needed? 4, what is the current and 2024 monthly average number of Clostridium difficile, or C. diff, affected patients in each hospital, and what is being done to reduce this? Thank you.
Thank you for your question. I'll pass you over to Steve. I believe we do have something to report back.
In response to question 1, the emergency department have a SOP for admissions which covers a process to risk assess all patients when they arrive in ED. Patients with suspected or confirmed infections are placed in a single room, or we would cohort patients with the same confirmed infection, e.g. norovirus. Response to question 2. The Trust complies with the requirements of NHS England National Infection Prevention and Control Manual for England when considering where surgical masks are required for infection prevention and control reasons, and when workers on site require the additional protection conferred by respiratory protective equipment, RPE. Our key control measures for respiratory infections are outlined in our Trust-wide risk assessment for COVID-19, flu, RSV, which is reviewed regularly. CSAF Internet, COVID-19, influenza and RSV. We are keen to ensure that all personal protective equipment is used appropriately in order to control the infection transmission risks present on our premises, while avoiding overburdening our workers with unnecessary PPE. This is particularly important when considering tight-fitting respirators, as extended use leads to impacts such as excessive fatigue and skin damage, and differentially impacts on workers with disabilities who may not be able to work in a respirator. We aim to strike a balance between competing risks in this way. FFP3S only confer protection on the wearer in the context of a valid face fit test. This process, see Respiratory Protective Equipment at Work, a practical guide, is undertaken with relevant staff members to ensure that their respirator protects them adequately. The Trust is not in a position to offer face fit tests to all patients who attend services on our premises. However, all visitors to site, whether patients, visitors, volunteers, contractors, etc., do have access to type 11R surgical masks and are encouraged to wear them if they can in the context of their health. Response to question 3. During the critical incident declared on Friday the 3rd of January 2025, the Trust postponed 3 elective operations and 18 outpatient appointments to reduce pressure on inpatient beds and to redeploy staff in the urgent and emergency care pathway. Response to question 4. The response begins with a table which will be shared with the published question in response. Reporting and compliance. All C. diff cases diagnosed in the hospital laboratory are reported to Public Health England. Since April 2019, the definition of the trust attributable cases has included samples collected on the third day of admission or later. The Infection Prevention and Control (IPC) team have undertaken significant work to improve the recognition of patients with diarrhoea and ensure timely sample collection. This effort resulted in an increase in the number of C. diff tests requested by staff. This increase in testing may have contributed to the identification of more C. diff cases during this period. The Trust continues to thoroughly investigate all identified cases of C. diff to determine potential lapses in care and recurring themes that may have contributed to infection. These reviews identified common contributing factors which have informed the development of a comprehensive action plan. Collaborative review and action. In April and September 2024, the Trust hosted a C. diff deep dive morning involving key stakeholders, including NHSE representatives, nursing leadership, pharmacy, microbiology, and the IPC team. The group focused on the 5 main improvement areas, identifying additional issues and actionable steps to enhance infection prevention efforts. Key learning themes. Learning from C. diff investigations has been grouped into 5 key areas for improvement. Number 1, ward processes. Early identification of patients with diarrhoea, timely isolation of symptomatic patients, effective decontamination of equipment and the environment between patients. Number 2, hand hygiene. Ensuring compliance among staff and encouraging hand hygiene among patients. Number 3, antimicrobial prescribing. Strengthening stewardship and governance to reduce unnecessary antibiotic use. Number 4, emergency department flow. Addressing delays and overcrowding that can impact infection control. Number 5, environmental decontamination. Implementing a robust deep cleaning programme to ensure a clean and safe environment. Education and continued improvements. An educational roadshow on C. diff was conducted in 2024 to raise awareness and reinforce best practices. The Trust also maintains a thorough C. diff reduction action plan, informed by the deep dive morning and ongoing reviews. Clear, tangible improvements are being implemented in ward processes, hand hygiene, emergency department flow, environmental decontamination, and antimicrobial prescribing. These combined efforts reflect the Trust's commitment to reducing C. diff infections and ensuring high standards and patient safety. That's the end of the response.
Good, thank you. That's quite a full response. There's a lot to digest there.
Thank you, Chair.
Are you happy with that response? So, and I'm sure it's going to raise some points because where I'm coming from, I believe the concern is people are coming into the A&E or into the hospital with a disease and passing it on, and we need to prevent that from happening at an early stage. That's where I'm coming from. Is that the point of your question?
That's absolutely right, Chair. That although these FFP3 masks are designed to be fitted to the individual, most people are able to wear them, and indeed they're used in many other industries without having a particular fitting exercise. And if we're trying to protect most people, and particularly staff, to stop them getting cross-infection, then the use of these is I think, important. But I have a couple of, I have a supplementary question, please. The first is, despite the deep dive into C. diff in 2024, staff has continued to see an increase in reported cases in 2025. And so what additional measures are now being taken to reduce the level to ideally minimal levels, and although it's not always possible to achieve a degree of 0, but the levels at the moment are very high. The second is that in relation to question 3, with regard to urgent care targets, the Office for National Statistics published on the 20th of January 2025 that patients who stay in the A&E departments of hospitals for 12 hours or more have twice the mortality of those who are dealt with within the first hour or two of their admission. And in the light of this, what additional measures are SAF undertaking to dramatically reduce the number of people that are sitting in the A&E department for 12 hours or more? This is of vital importance, and I would again suggest that more action is taken to divert staff to the A&E department, because people who are waiting for routine operations such as varicose veins or hernias, they quite rightly deserve to have their operation done. But they're still going to be here in a week's time. The people who are dying, waiting to get into hospital, dying in the emergency departments and dying in temporary escalation areas will not be here. And so these people deserve priority. Thank you.
Would you like us to do with your question? You suggest we present it to staff?
Yes, please. Yes, please, Chair.
Thank you very much indeed. So really, one of the points you're raising is that the work and preventions they've already put in are not working.
I think, Chair,
Because
they're not working adequately. They're not working quickly enough. There has been a reduction in the number of patients who are in hospital with no reason to reside, and that's reduced from an average of 150 per day down to 100 per day. But this should be almost zero. Thank you.
Thank you. We will ask those questions and get a response, hopefully. Thank you very much indeed. Right. We might have to go on to item 6, aren't we? Going to read it? Oh, okay, good. Public question. Whoops, sorry. I'm excited now. Public question time. But our member would like to ask the question.
You need to be able to use this microphone.
Yeah.
Thank you.
And welcome.
Thank you.
Okay.
Thank you, Chair, and thank you to the committee for allowing me to do this. My name's Beverly Waite. I'm the Mayor of Ludlow. The Ludlow Hospital building and services have been deteriorating over the last several years. Ludlow town has a population of over 11,000 residents, plus the new housing estates in the parish of Ludford, and also serves a considerable hinterland of rural residents. They deserve a better service locally than offered at present. Could you therefore answer the following questions for the residents of Ludlow? When will significant capital works be carried out on the building to secure it for Ludlow people? What is the level of staffing at present on the wards? How much reliance is there on agency staff? How many beds are open and what could the bed capacity be with the correct level of staffing? When will Shropcom engage with the community to help with recruitment as happened so very successfully in Bishop's Castle? When will the scanner bought by the Friends of Ludlow Hospital be returned and staff recruited to run it? And what plans are there for other services to be added to reduce travel for many of our vulnerable residents? Thank you for your time.
Thank you. Can I ask you a question? Can you just clarify about the scanner? When will it be returned? What happened? Are you able to?
The Friends of Ludlow Hospital bought a scanner. And because there was nobody to actually use it, apparently it's disappeared and gone to Telford, where there are staff who can use the scanner. So it was purchased for the hospital by the Friends, but because they had no staff, they said there was no point it being there.
And you obviously want it back.
We'd like it back.
It
Some
was
staff to
purchased.
run
I
it.
can understand that.
Yes, please.
Thank you.
Thank you very much for your time.
What do we need to do to answer these questions?
So a response has been sought and provided by Shropcom, which can be read out now. So it's available, but it's also available to be published as well.
Mind reading it? Is that possible?
Absolutely.
Thank you.
So in response to question 1, NHS Property Services, NHSPS, is responsible for the capital programme to ensure the community hospital site in London remains safe for delivery of healthcare, and it makes decisions in relation to any significant capital investments at this site. However, Shropcom also invests in a smaller scale programmes at Ludlow Hospital to improve patient care and experience, including redecoration of patient areas, refurbishing clinic areas and toilet facilities, and improving the car park area. Response to question 2. The Trust complies with the National Quality Board recommendations to determine safe levels of staffing for inpatient wards, and in line with the Trust's safer staffing requirements, the baseline staffing for Ludlow ward is as follows. Early shift, 3 registered nurses, 4 healthcare assistants. Late shift, 3 registered nurses, 3 healthcare assistants. Night shift, 2 registered nurses, 2 healthcare assistants. In addition to the above, the staffing levels are reviewed on a daily basis to take into account the acuity, complexity, needs of the patients, and additional staff are put in place as required. As an example, for the last 6 weeks, there have been an additional 2 healthcare assistants in place due to the number of patients needing community beds with enhanced care needs, and it is envisaged that this will continue for some time. To always ensure safe staffing levels, the Trust monitors the fill rate for both registered nursing and healthcare assistant shifts. This is calculated using planned work hours versus actual worked hours. The Trust is currently operating with a fill rate in excess of 100% due to the additional healthcare assistants working as outlined above. Response to question 3. The Trust utilises agency staff as required to ensure that safe staffing levels are met, but all shifts operate with a majority of substantively employed staff. The use of agency is particularly helpful in enhancing staffing beyond usual levels in order to meet additional patient needs. Response to question 4. How many beds are open and what would that bed capacity be? Ludlow has capacity for 24 inpatient beds, all of which are open. Response to question 5. The Trust has a small number of vacancies in Ludlow, going through a recruitment process, but has not identified a recruitment challenge, as was the case in Bishop's Castle, and therefore does not currently have a requirement to run any ongoing recruitment campaigns. The Trust would, of course, welcome the opportunity to work with the community on any future campaigns needed. Response to question 6. We believe the question relates to a scanner purchased by the League of Friends and utilised for a service run by Shrewsbury and Telford Hospital NHS Trust. Shropcom have not ever provided services utilising the scanner. Any questions regarding reinstalment of services using the scanner should be referred to Shrewsbury and Telford Hospital NHS Trust. Response to question 7. The Trust is committed to working with NHS STW and wider system partners and the community on service opportunities for Ludlow. The following plans are in discussion. Enhancing Services in South West Shropshire Working Group has been re-established, with the ICB now leading to ensure a full system level of engagement. Conversations around supporting early supported discharges from our inpatient beds onto virtual ward have started. Plans to provide a health and wellbeing drop-in for the community to access clinical advice and guidance earlier are being planned for early February. We have also started an art of the possible conversation about supporting virtual outpatient attendances. Planning session in place to implement an integrated neighbourhood team model within each of the localities. The following are in place in Ludlow. 0 to 19 services in the Ludlow area. We have health visiting, school nursing services, and FNP delivered in those areas. We go into schools in that area, and we may have some service users in that area that are signed up for our FMP service that don't operate out of clinics or the hospital. Health visiting, we operate from Ludlow Hospital. That's the end of the response.
Good, thank you. Response. Who was the response from?
That was from Shropshire Community Health Trust, Shropcom.
Thank you.
Chair, could I just, I know I'm not.
I was going to ask you what do you think of that response, and are any comments?
Well, I've organised a residents' community meeting about the hospital on the 4th of February. I contacted Shropcom and all the relevant organisations. Everyone has refused to come to us. They've said that they will speak to us. Firstly, they said they will speak to us individually as groups. They were happy to come and speak to the council. They were happy to speak to the League of Friends. They were happy to break us up into different groups. I contacted all of the groups that are coming to speak to us, the doctors and everybody else, and they've said that that's not what they want. They want to speak as a group. So I've now contacted Shopcom and said we want to speak as a group. And they said, yes, we're willing to do that, but not until after the residents have said what they want. What the residents want, Chair, is a hospital that functions. They're making it so expensive to run a clinic because there are so few appointments that eventually it will be too expensive to keep that hospital open for clinics. And all the clinics will then have to move up to Shrewsbury. Most of the residents, not all, but most of the residents are older, more vulnerable people. They won't be able to make those clinics. They won't be able to come to the clinics. And if they do, it will cost a lot more in ambulances to take them because they won't be able to drive. Ludlow Hospital's clinics are disappearing. Audiology is now 1 day a week. Physiotherapy is dropping. And they're saying that they're not doing it. The residents of Ludlow believe it is being done by stealth. The fewer people can get appointments, the less the hospital stays open. Yes, they've got 24 beds open, but there used to be a lot more than 24 beds. They've just closed the wards. So they're running the capacity of what they've got open, but not the capacity of what it could be done. They've sold off part of the hospital because they don't want to keep it. It's now an arts venue that sells alcohol and has afternoon coffee. So we're watching our hospital disappear, and I'm afraid we can't do that. That's all I can say today, but thank you for the opportunity.
Thank you. Yeah, okay, just Bernie would like to ask you a question. Thank you for that.
Thank you, Chair. I've been involved with the Ludlow request to increase the services as much as possible, partly because it's required, but also the Shropshire Telford and Wrekin Integrated Care Board have specifically stated that they wish to increase facilities in the periphery, in their hubs, of which Ludlow is one. The Ludlow Hospital, although it has a capacity of 24, it's currently staffed at 24. It has a capacity for up to 40, and there's no information about occupancy. That is how well that the inpatient beds are being used. Ludlow should be, with a population of 12,000, should have substantial clinics and other services locally. But as Councillor Waite has said, they're disappearing. And this is clearly wrong and needs to be reversed. The final thing is that the Integrated Care Board has stated that it wishes to engage with local people. And this is exactly the opposite. So will the Integrated Care Board please actively engage with local people in the hubs of Shropshire, and particularly in this case, in Ludlow? Thank you.
Thank you very much.
That's for the Integrated Care Board, please, Chair.
This will be coming up in our work programme discussions as to what we should do about this. In response to Councillor Way, if they've written to you to ask what the public want, I suggest you write to them and tell them exactly what you've just told us, and tell them that that is what the public want. If they don't want to talk to you, there's not much we can do to force them to talk to you. But I think if they're suggesting that you tell them what you want, and then the next stage is a response from them. And you can also feed that into our future meetings. And I would very much imagine that this committee would try and support you, because it is what we all want, is services being delivered locally.
Yeah.
But I can't say any more than that at the second. But I do suggest you write back and say, okay, you requested what the public wants. On behalf of the public, our group suggests this, this, and this, and give them a timeline to respond by.
Okay, thank you very much.
And please keep us informed. And I can't go into great details because it's not on our agenda. It's a question that has arisen, and we can look at it in the future as part of our work programme and help support you, because it is something that this committee want these local services delivered locally and being accessible. So I'm sure we will support you in any way we can.
Thank you very much.
Thank you very much indeed for asking the question. I hope you found that beneficial. Okay, right.
Yeah,
Very
can I
quickly,
just
Evan,
I'm not sure that they've answered some of these questions properly.
No.
I think they're very high level. And actually, if this is put on the work programme for the future of our community hospitals and Ludlow in particular, which I'm sure we will do, then we will need to get more detail around improving the inside of the hospital. Now, I haven't looked at the outside of that of Ludlow Hospital for quite a while, but last time I was there, it was covered in scaffolding. Right. So actually, I can't see, because there's no work going on, that actually that will have improved. And unless you make the building safe, as they didn't do with the maternity block there, which then became so unsafe that they hadn't got the money to deal with it, then actually the building will not be usable. And that worries me. But so I think some of these questions we need to go into in more detail. So if we can keep those so that we get that detail from them when we do some more work on it, it would be really useful. I also wonder whether when we get to the local care neighbourhood working part of the agenda, whether there are any updates around Ludlow that might be put into, and whether some of that community working will actually be happening from Ludlow Hospital, because I know that Ludlow was on that list originally.
Thank you. I think as you say, we can ask those questions ourselves, yeah. and we will get an answer whenever. Yes, Jeff.
I wasn't sure that the scan question was answered properly. Where is the scanner now? Are they going to bring it back to Ludlow, and are they going to train a team to operate it? Because, you know, I was on the Friends of Ludlow Hospital and discovered that the scanner had gone to Telford and it wasn't clearly told where it had actually gone. You know, I'd be appalled.
Okay, thank you. I agree. So when you get your response, would you kindly let us know, keep us updated, because I'm sure that we all want this to happen. And I understand you're upset because if your local residents have collated money to buy some equipment, you want the local residents to benefit from it and be able to use it. And that makes good sense to all of us, I think. And I'm sure that we will help in any way we can to ask those questions.
Thank you.
Thank you.
Thank you.
Thank you very much. Thank you very much indeed. Yeah, I agree. I don't think you're all the answers you wanted, but let's pursue it. Right, item 6, local care neighbourhood working. To receive an update on local care neighbourhood working. Rachel.
Thank you very much. I think I'm just going to introduce this item and then hand over to Penny and Claire, who are going to take you through some of the detail. Really pleased to bring this report to Scrutiny today. This is the report will provide an update on the neighbourhood aspect of the local care programme. Obviously, we've had updates on local care committee previously. It's a start of a more detailed conversation, introducing some of the work that's been going on. I think the important bit in terms of this area of work is it is an ambitious programme that seeks to address a number of areas of work. One is obviously the prevention, so having much more preventive approach in all that we do. Tackling inequalities and variation across our communities, so actually all being based in local need, in our understanding of local need through things like our JSNAs and other work programmes, so making sure that it's very much locality based, one size doesn't fit all. It's about joining things up, integrating services, a range of services. It is absolutely about partnership working. It's about working with those partners in those communities. So I think it's a huge amount of work is being done. There's a lot more to do. So I think it's a really important point to bring that to the committee, but bearing in mind those important elements that we've described and what's important for Shropshire, so that prevention, inequalities, locally based, understanding needs and building from there to ensure that people have got access as close to as possible, and that partnership working. So whilst we've got some colleagues here, the many partners who are involved in this aren't necessarily all represented around the room. but welcome your view, your input in terms of the direction that this programme's going in. And I'm going to hand over to Penny and Claire, who will take you through more detail.
Please.
Thank you, Rachel. Thank you, Chair. The presentation, are you happy for me to share it on the screen?
I'm more than happy.
That it works. I don't share the wrong thing, which happens from time to time. Right.
Good.
So thank you very much. And just to say, we did provide a paper. That was fairly long, so apologies for that. But there's been so much going on over the last 18 months to 2 years, and we wanted to make sure that the kind of breadth of the programme was included and that the connectivity, the whole range of elements were part of the thinking around this, and really keen to have a conversation with you. So my name's Penny Basin, Head of Service Joint Partnerships. It's a joint role with the ICB, STW-ICB and Shropshire Council sitting in Public Health.
And I'm Claire Parker. I'm Director of Strategy and Development for the ICB.
Thanks for asking us here today. So we just wanted to very quickly let you know that the work that we're doing is very much embedded within the Shropshire Plan, the STW Joint Forward Plan, and our Joint Health and Wellbeing Strategy. And some work we did about a year to 18 months ago around the prevention framework really provided us a bit more detail as to how we want to take forward that work. And the priorities of the prevention framework are access, integration, person-centred care, and communities, which again align with our strategic approach. But then within those priority areas, there were some key actions within that around developing the work to ensure that we're embedding that preventative approach. And some of those key activity areas included developing integrated working, multidisciplinary teams, and developing community and family hubs, and then ensuring we're working with our community in a very person-centred way and focusing on how we can work collaboratively with our community and voluntary sector. So through the development of the prevention framework, we had sort of a joint workshop where we were saying we're working as one in Shropshire. We're moving back to actually Shropshire together rather than one Shropshire, but which is a long-standing partnership way of working. We asked our range of partners around what is it that we need to do, what are we trying to do here, and collectively agreed that our real strapline for this is making it as easy as possible for people to stay healthy, happy, and connected in their communities. And I think the conversations you've had and the public questions you've had have really aligned with that thinking. And so how are we embedding an approach that means that people can stay healthy and well in their communities because they have access in their communities to the things that will keep them happy, healthy, and well. So, and again, just actually, as we were talking, I just popped this in because I thought it would be helpful to just see from a strategic approach what's been agreed at a system level. So the Shropshire Neighbourhood Working is very much now being led through the Shropshire Integrated Place Partnership, and the chair of that and the leader of that is Andy Begley, our chief executive. And in Telford and Wrekin, it's the same. David Sidaway is the chief executive there at Telford and Wrekin Council. But embedded within the work is that end-to-end NHS pathway. So recognising that we want to keep people healthy and well, and there's a whole range of things in the community that we're aligning and developing, and there's a whole range of universal services that connect very much with what the council does, but actually also there's the element in making sure that when people need NHS services, that those end-to-end pathways are really clear, well understood, and connected to the communities. And that work's being from a senior leadership perspective is being delivered by the Community to Health Trust and Patricia Davis. So that's at a system level. Again, over the last couple of years, we've been working collectively on this, and really this approach has come out of looking at the Primary Care Network Association, looking at also, but right across to our early help strategies. What is it that we need to do to make this work, and how can we work together, and what is the approach we're taking? And it's back to what we've said already. People are at the centre. What makes people healthy and well is those things immediately around them, a very public health approach. But actually, we have a role in making sure that that's available, like the community and voluntary sector, like good access to infrastructure in your area. And then when we have universal services, so the slightly darker blue, again, that they are connected and work well. And when people need access to those secondary care services, that the pathways are clear. And I think that is what we've been referring to this morning, and that is where we are now, is making sure that we've done a whole load of work in that universal area, and more will come around the hubs and around integrated working. And the next phase is moving us into that integrated working from an NHS pathway perspective. So, but it isn't just NHS. There's a whole, as you'll know, our services and secondary care services, secondary need services are broad, and are along a range of partners. I think this was just trying to simplify what we've been doing. So we've been working and using data to identify need, understanding things like, I'll come on to it next, rural proofing and all of that elements, understanding what our communities need, using the place-based needs assessment, changing the service inputs based on that need, and working to improve outcomes. So one of the things that we really wanted to make sure that we didn't get into the paper but should have done was that addressing rurality, because all of the work that we've been doing has been around recognizing that we have a vast county, and we have transportation problems, and we have all kinds of issues. So with this vast county, how can we make sure people can access what they need? So we've been working through addressing rurality through a vulnerability interactive map, and then putting that alongside our place-based JSNAs, and looking at performance data as well. So we're really understanding where are the areas that have easier access to services than others, using information around housing, health, deprivation, crime, transport, drive time. So drive time was a big one with this. How long is it going to take you to get to our services? And this next one shows it in a bit more detail. You can see the south. Heather, you'll recognise this. You can see this in the southwest pretty clearly. Yeah. Southwest has a real, which is why we are working on developing our approaches in Bishop's Castle and Minsterley areas there. So what we're doing is we have our, we'll get onto the hubs in a minute, but we've got our main hubs, but actually we're using this vulnerability mapping to say, okay, if we're going to have mini hubs and make sure that we can address need in very local communities, where are they? What are the communities we're talking about? And it's absolutely driving it's using that intelligence data understanding to drive our decision making on where we're going to be putting things. So this is a building picture. We've got to a certain place, but we're really working to push on now. We're using this kind of data. So our core neighbourhood programmes include the community and family hubs. So this has been something that we've been really driving forward in the last year. Proactive care, which the ICB have been leading on and developing that real understanding of how can we use, with proactive care, it's using data, individual data, to understand who needs help before they go into crisis. And that is working in the southwest, working with our NHS partners in the southwest across social care, across health, across the voluntary sector. Integration. So over the last 18 months to 2 years, we've been developing our integrated practitioner teams around children and people and families. These are now business as usual. We cover the whole county, schools, early help, NHS, whoever is worried about a child or a family and is not able to make progress as an individual organisation, brings that child family to a discussion. It's a multidisciplinary approach, and we're making great progress for understanding. And actually the teams, one of the fantastic things about it is the teams just learn how to work, who else is working in the patch, who can they go to when they have a question about safeguarding, when they have a question about health and mental health, and how can they work together to address the needs. The neighbourhood working integrated teams, so there's multidisciplinary teams being developed around dementia as a starting point in the southeast of Shropshire, and then that's looking to be how can that be expanded. That's been led by the primary care network there, along with multidisciplinary approaches to pain management. And then, of course, we have the mental health care planning forums, which we're working alongside to understand. They were there first doing this MDT approach, and we're using their learning to develop our going forward, and also see, well, how can we make efficiencies by working together? We have the developing women's health and wellbeing hubs. We are working with our early health colleagues on their transformation, which are all embedded in this, and our adult social care. So recognizing that the front door of services is really important here. So how can we do this together? It's not separate, it's together. And then delivering that prevention framework. So our integrated practitioner teams, like I said, they're working across the county. It's business as usual. This is hard to see, but I'll send these. That I was interested in showing this because what we're working with as well is understanding what the risks are to our communities. And this demonstrates that the families we're working with, the number one issue, risk that is repeated with almost every family we work with is mental health. So we know locally we can feed this into the work that we're doing and actually really understand how can we support people in their mental health. Families, a lot of the families have been known to targeted early help, and the risk of escalation and exclusion from education is a key risk as well. So these are some key things that we're really working to reduce, and then you'll see that in the metrics when we talk about that. Our hubs, again, we have our hubs. We have 5 hubs up and running around, well, 6 in fact, including the Highly Health and Wellbeing Centre. And within those, there's a core offer, which I'll go through in a minute. We're also developing hub in this. We've had a struggle. We've always envisaged having 7 main hubs. We've had a struggle with estate just to find the right place in Whitchurch and in South Shrewsbury. We're making great progress on that now. We're working with partners in South Shrewsbury and with the library service in Whitchurch, and you'll be really familiar with that issue with RASC. That's the one in Whitchurch. So, but we are getting there. So moving forward with that, which is really, really positive and back on track from those 2 places point of view. But it is all age. So we have started with the core. We offer being around children, young people and families. The hubs are absolutely all age, and that offer is developing. And I think one of the key things to say here is that we've been working really closely with our library service across, in particular, in 3 locations. So Oswestry, Bridge North, and now Whitchurch, and there is fantastic work happening, reducing duplication, so making efficiencies from a state point of view, but also making a really good offer for local people. I won't go through this, but this was just to let you know our thinking was really broad. It was about the vision is about open door access and how many people can we work with. And we recognise we can't put everyone in one building, but we can make sure that the offer could be, you could have a virtual offer from the building, which we do have for our housing colleagues, a direct line into housing if somebody comes with a housing query that we can't answer then and there. Again, once a month offer is now developed with our Shropshire Recovery Partnership around substance misuse. So all of those kinds of things, they might not be there every day, but the really clear lines into how to access them when people come through the door. And this slide just showing you the benefits. So we want benefits for people first and foremost, easier to access things in our community. But we also know that we are working towards creating efficiencies across the local authority, but also efficiencies with our partners. So the kind of organisational benefits are financial, but also non-financial, because staff are working collaboratively, collegiately, and they are reaping the benefits of having a broader sense and understanding of what else is out there in the communities and how they can work together and create that confidence in the work that they do. So there's the core offer, which is expanding all the time, I'll just say, and then the hubs, which I've already said, multidisciplinary teams we've already talked about, and again, these will be shared so you can see them. And the one thing I didn't mention is that we're working with the community resource on working with the village hall networks as well. So thinking about where can we work with what's already in a place in a very local way, and testing out some hub approaches through village hall approach. This slide was just to highlight the fact that it isn't about signposting. Would you like me to pause?
No.
Did you have your hand up?
Yes, Penny, I was signalling to the chair that I wished to speak.
Yeah, do you want me to pause now?
No.
No. Okay, keep going. Okay.
Carry on.
Okay, thank you. So it isn't just about signposting. It is and leaflets and sort of, well, I don't know the answer. Here's a leaflet, off you go. It's about working with people where they are and creating a good understanding about the offers, training our staff and volunteers. How can we help? We won't always have the answer, but the approach will be different. The approach will be how can we help, and making sure that people get the answers that they need, if not then and there, in the very near future. The last few slides are just pulling out some of the examples. So in Oswestry, the Community and Family Hub is in the library. There's just a load of activity and building activity going on there. There's a winter warm welcome now happening with free tea and coffee and a whole range of other activities going on. And there's an improved offer around SEND and just fantastic joint working going on there. The same with Ludlow. Different focus. We've got different partners involved with different things happening. But as Men in Sheds, you can see as an example, have been helping us with it. But so have Ludlow and Area Community Partnership, looking at that front door. We're really working closely with our voluntary sector. And in every hub, I haven't said, but one of our core things, which would have come out in the paper, is that we've got our health visiting open access clinics in all of our hubs. So they're so people with children under 5 are able to access that at a range of either once a month, once every 2 weeks, or once a month, depending on where the hub is. And so that's an absolute new and improved, well, revisited offer, I would say, but hasn't been there for a while. So that's really fantastic. And the clinics are seeing up to close to 500 children a quarter through those open access clinics. Highly, we have a health and wellbeing centre with a GP offer in the Halo Leisure Centre. The partners there, Halo Leisure, have been a fantastic partner. So have the NHS, working really closely with our primary care network to make that happen and improve that offer for local people. The new library and Highly as well. I won't go into detail on that. The Highly, and also in Highly was our first place where we launched the Women's Health Hub, working in partnership with our primary care network, working with the ICB, working across a whole range of sexual health services, and we had a menopause, what is menopause event at Highly, and there's multiple events since then. Again, there's the open access clinics there. The whole range. So what to say about the Women's Health Hub? So this has been taking a whole system approach, working across primary care networks, in particular with the NHS, and providing additional funding with those primary care networks to offer additional services in their area. A big part of this work as well, because there's no guarantee of recurrent funding, is to develop a really good training offer. So ensuring that our clinicians and those allied health professionals, but also others, are able to create a really good understanding of what women's health needs are and how to address them in their local area, creating kind of that sustainability for services going forward. Each of our primary care networks across Shropshire, Telford and Wrekin are involved delivering with, and also with a focus on inequalities to each one. So for example, in the Southwest, the primary care network have been working with the Muslim community there to understand what is it that's needed for them improve their health and wellbeing needs, and working closely with MPFT with sexual health service as well. So this whole program has been about bringing together services and delivering in a more efficient and making sure that people have access to services. Was there anything else about the women's health there?
Just to say that although Highly was the first hub, there's now a system-wide access to hubs, and as Penny said, we don't have recurrent funding, so it was really important to make sure that the training offer is there, so that we can make sure that our clinicians and volunteers are offering similar services based on need. And a number of menopause talks have happened across the county and across the system, and have been really well received by women accessing those. So yeah, it'd be great to get some additional funding to do more. But actually some of the impacts on our really sort of 420 plus communities, so those health inequalities have really struck a chord with some of our primary care networks, and they're looking at some different projects. So that's really encouraging.
This was just an Amber Hub, put it in just to say every time that we do something, we also ask people for their views on what next. So this was an example of that from the Highly offer. And this is another example of how we've been bringing together different bits of services to embellish and enhance the offer by working collaboratively and injecting a little bit of the additional funding that was offered. Family Nurse Partnership already have an offer around the sexually transmitted infections. They have that expertise and understanding and are able to talk to their client group. But actually, by doing this together, we've been able to share information and do some additional work around this. And they've got an ability now for people to phone in with concerns. So it's been connecting up different parts of the system who do have the expertise, knowledge and understanding, and being able to join that up with each other and share knowledge. Our libraries are involved as well. So there were, as an example, Menopause Awareness Month, there was an offer across Shropshire and Telford and Wrekin around our libraries, increasing that knowledge and understanding. So we are capturing data. So just coming to the end now of the presentation. So it is a developing piece, this, because we are capturing data. We're starting to understand that does all this additional input into activity. So seeing 500 more children through health visiting a year or a quarter, sorry, additional inputs into our early help offer, increasing seeing families, is that having an impact on the kind of the high end people needing to have children in need, or into children coming into care, as an example. We're starting to see some green shoots on that, which is really exciting, and we just want to do more now. But the outcomes that we're looking for, so you can see there's a whole offer, a whole increase of inputs and activity, but then the outcomes we want to know is, have we got a decrease in children and adult social care? Are we able to really pull that down? We want to reduce the number of not in education and training children. School exclusions and increased school attendance and decrease exclusions, accidental, non-accidental injury, ambulance call-outs, school readiness. So got meets several times. So you can see the range of things there that we're looking at, and the programme is developing that dashboard to be able to understand and look at all of that. So this is just a whistle stop of some updates. So we've talked about a lot of these things. I would just say that we're working next month. We've got a workshop with our Shropshire Integrated Place Partnership and Health and Wellbeing Board to ensure that we've got our priorities aligned and addressed for this coming year, along with the work programme. We're continuing that alignment with our strategic planning, and then it really is to push forward that end-to-end NHS pathways and to that ShropCom leadership. So those are the things going forward. Yeah.
About the NHS pathway development. I think it's pertinent to the previous discussions and the public questions. We really want to, we've got 3 priorities. So the first priority that we just relaunched is diabetes, which we're taking a population health approach, led by Lorna Clarkson, our Chief Medical Officer, and myself actually. We want to design that pathway approach through more local care and community-led care rather than any acute care. So we will be making sure that we've got experts by experience, we've got the rural proofing toolkit that we need to apply to the work that we're doing, and actually that co-development around the hub and spoke methodology in the neighbourhoods is the foundation of how we're going to do that. The other priority is around frailty or ageing well, and we've included some of the dementia work within that, again, because that has an impact on the urgent care system as well. So we've got an overarching strategy. We're just about to relaunch and work on that. There's a number of project groups that will sit through that, and again, we need to develop that through the community work that we're doing. The other bit I just wanted to mention is we're further developing the conversations. It's been slow, and I'll kind of look ahead those cross-border partnerships. So working with Powys, I had a conversation last week about how we work with Herefordshire and Wye Valley to create a much more seamless transition across the south border. But certainly the sort of the Marching Forward partnership, and there's a whole health programme around that. We want to have a reciprocal arrangement so that it's easy for people who are living and working in Wales or vice versa, that they can use and access services that are closer to home. And also Herefordshire are developing a neighbourhood approach as well. So there's some work going on in Knighton, for instance. So that might be of interest, particularly in the very sort of far southwest corner. And then the final priority, which we will launch later on this year, so we've got some further work to do, will be around cardiovascular. So we'll be focusing on cardiovascular prevention, hypertension, target treatment, etc. And again, that will be a population health needs-based approach that we want to work on through our neighbourhood partnerships. So we will be talking to the communities about how we deliver that through the family hubs and their communities. How do we get some outreach to the villages and those kind of harder to reach, travel, access, all of those kind of things. So it's quite exciting. It's been a long time coming, but actually I can see the light at the end of the tunnel with this. It's not going to be easy, but we'll keep pushing forward. And I think the government approach around neighbourhood health as well will help kind of put a bit of a focus on this work that we've done quite a lot with, not very much, haven't we, over the last 2 years, I would say. So just wanted to add that.
Good. If okay, I'd just like to say two other things. One, the ICB has also, and it's already been really, really helpful with Claire's team, have additional resource to support the neighbourhood working. So we've got some additional resource in person to do that, which is fantastic, and we're working really collaboratively. And then the other one was just around the approach. So we are taking that very local based approach to develop, does this work in this area? So looking at MDTs in the southeast as an example, okay, that's worked really well. How can we replicate that elsewhere? And we've been really focused on doing that because of the size of the county, recognizing that it's very difficult to develop and deliver things across a whole patch all at once. Taking that approach. So what you will see initially is some things happening in some areas with a vision to it happening everywhere. And it's with integrated practitioner teams for children, young people and family. That's how it works. And we have been able to make it business as usual for the whole area. And that is the approach, and that is the vision for going forward. So yeah, I wanted to talk about that because sometimes it might feel like it's slow to come in your area, but we will get there.
Good, thank you. That was a very enlightening presentation. I've got one or two members would like to ask some questions. If I just ask, the GSNA is obviously identifying local needs. Is that what's driving where you're going to put some of these services, or is the demand for some of those services driving where they go anyway, basically? And what are your challenges?
So what we're working on is the place-based joint strategic needs assessments have given us there's some commonality across all of them, in fairness, and I think mental health and children, young people tend to come out really as a real focus for all of them. But then what we can do is understand the individual needs of the area, and then through the hub approach be able to put in some additional activity that's aligned to what's come out of the GSNA and what the local people are telling us. So there's that core offer, but beyond the core offer, it will absolutely focus on what's needed in a particular area. And we also need to look at demand and understand, what people are coming through for from a health perspective, and then address and align according to that as well.
And we're doing the same for clinical services as well. So we're using sort of the data that we have from a health perspective through primary care, etc., to map and risk stratification as well, so that we're modelling the right services for the lower end at prevention, right at too complex. We'll want to deliver the same outcomes wherever you live, but actually the way you deliver that might be different for your community or your area, and how we do that. The challenge that we have is for clinical staff, we have to maintain their competency. So if there's only one person in that particular area, we have to think about how do we deliver it to a group of people, and we're just trying to think outside the box when we're doing that. So, but delivering that local care close to home, so people don't have to travel, into Shrewsbury or up to Telford for the majority of their care, is our aim. Certainly our aim. Right.
Yep, I understand that. Thank you. Jeff.
Thank you, Emma. I'm Jeff Anderson. I'm the county councillor for Halskirts. And within Halskirts for the past 4 years, we've been working to reopen a community hub in the centre of what is probably the most deprived area in Shropshire. It's a large, dense community of the type of population that needs the most support. About just over a week ago, we were visited by 2 members of the public health team, Amanda Cheeseman and Hannah Thomas.
Yeah.
From public health, and we were delighted to have them visit us. Lovely people, because we have a centre there that we've fought to keep open over the last 4 years. At best, we're break even, we're probably sliding now backwards. And if we're desperate for you guys to get involved, because here we are, we're smack in the centre of the toughest area in Shropshire, crying out for you guys, right? And these 2 lovely people came in, and everything they said, the rest of the trustees were there, they presented, and we want you, and I'm desperate for you guys at the highest level to give these guys the maximum support to get something moving in Halskirts. It's ideal. If you don't take it now, I suspect in 12 months' time the community centre will have gone under. So we not only need support in terms of the various things you're doing, but also, if possible, because if we're going to give you this space that's costing a fortune to heat and maintain, if you could contribute towards the heating and maintaining of the premises, that would be marvellous. So you've got an ideal spot. It's smack in the centre of a community that desperately needs help, and you've got 12 months to grab it and help us. If you don't, it won't be there anymore. But it's perfect. There's meeting rooms the size of this, one even larger. It's exactly what you need.
May I come back, Chair?
Yes, please.
Thank you. Yes, we absolutely recognise the facility. I've been there. In fact, I went on Thursday because they had bacon butties. I was very happy. I was very happy with that. And one thing that I noticed about the building is that it is in the toughest area in North Shrewsbury. And there is not a mark on the building. You guys painted it white.
Yes.
And there is not a tag. There's nothing.
Yes.
Because it's respected by the community.
Correct.
But it is amazing. So we are really focused on supporting, and the conversations we're having is around having the health visiting clinic there, which you probably had with Amanda and Hannah, and moving that. So it will probably take a couple of months for that to work through, but it is happening, and we are really keen to work with you.
Can I come back on that point?
Of course you can.
The centre is well respected by the community. Prior to us taking it back over, it's been heavily vandalised. Every single window was smashed. There've been all sorts of nasty things going on inside. People have broken into it, and the local community, it's not any authority or anything like that that's put it back together. The local community has put it back together, and there's some lovely ladies there who live, local residents, and they run it, and they're doing it totally voluntary. But we are, after 4 years now, they've had to go and get jobs and this, so we are starting to slip. We do need finances so that we can do further repair on the building, and we really need a centre manager to come in, and for us to be able to afford that, we need some funds coming forward. We've got about 7,000 in the bank, but it's starting to drift backwards. So we're not bankrupt yet, but if you project our income versus our outgoings, we've got about 12 months, and we do need, not only the community to come involved, but particularly you guys to come in, help support us. It's the ideal centre for all the issues you've put on your charts. You could run all these services from there, and we'd be delighted to have you.
Thank you.
Yeah, thank you. I guess it's going to be a problem. Each town, village is different, isn't it? Because you're trying to deliver services as you say, in the right time and the right place, and finding the right place and making that accessible. A lot of your volunteer work apparently appears to be in libraries. So whatever the county does with libraries is going to restrict the hours that people can access it anyway. And actually, this how we safeguard that they are going to be available. So I can see there's so much here that we can all work together on, and it's something that is really, really, for me, essential, because people can't travel because of age or lack of transport. People can't use the internet. They are stuck at home, and they need those services delivered to them in some shape or form. Okay, thank you, Bernie.
Thank you, Chair. Penny, I'm delighted, as I'm sure we all are, to see this initiative going forward of neighbourhood working, and also delighted to see what success there's been in Highley, which has a population of 3,700. I represent Meal, which has a similar population, but has no community hub. And this is after almost a year of working towards developing a community hub for South Shrewsbury. My constituency also has the 5th most deprived community within Shropshire on Meal Estate, and this has been neglected for over a decade. I've asked for some resource to be put into a local facility, but as yet a single hub has not yet been identified. There are some piecemeal services provided in the local school, and I gather about to be provided in one of the housing associations buildings. But this in no way helps to provide the services that are required for South Shrewsbury and Meal Estate in particular. So what can you do is the question I ask. I've asked for 2 of the houses to be perhaps leased or taken over in order to convert and develop into a community hub. But short of this, I struggle to see how you're going to be able to do it in the short term, because part of the deprivation of the area is the fact that there are no buildings that are suitable for use or conversion. But yet this has not been addressed. The second thing I'd like to mention is that you very rightly talk about liaising with local population, but the local population of Meal have not heard anything. And I'm not sure that the local population of Ludlow have heard anything from the integrated care system about what you're putting in. So what are you doing to engage with local people about these services, which are all very much needed? You drew attention to women's services, which of course are desperately needed. Gynecological appointments are amongst the longest waits in the NHS, and women are suffering enormously because of the lack of access to services. So what specifically is happening to target that area? And likewise, mental health services are also quite rightly identified as being an important priority. But what resources are being put into bringing those waiting lists down for mental health services in the community? Because these facilities that are going in are great in a qualitative sense, but what do they do to actually improve the healthcare of women and those with mental health illnesses in the county? Thank you.
To respond.
Thank you, yeah. Shall I start? And then Rachel may want to pick up around finances, and Claire a bit more around the women's health element. So, I mean, I think, as you know, Councillor, because I think you've had quite a few conversations with our colleagues, a range of colleagues about this. We have struggled in the Meal estate to find a state. So, but we have, as you pointed out, we have recently been able to kind of solidify a partnership with Homes Plus. So the hub, the community and family hub, will be located at the Homes Plus offices, and there's the offer is building there. So the first thing that we'll open up with is early help offer in that building, and also with the open access health visitor clinic. And then we'll build from there to understand what else is needed in the community. I think that, as you said, that work has been ongoing. We have had real focus on Meal because we understand the issues there, and we have been working towards a solution, and that is in train. There'll be more to do, and there'll be more to talk to the community about, and there'll be more to understand, but we can only deliver within what we've got, and that's what we've got. And we all recognise the financial position of the local authority. Probably worth saying, I should have said already, is that some areas with the community and family hubs received additional government funding. We did not. So we have put resource into this, but it's been about shifting resource as opposed to any new resource. And so we've done it with as much as we can, in a positive way, by working collaboratively, making efficiencies. With regard to engagement, we've done a huge amount of engagement with communities. So in Ludlow, I think it was about 900 people responded to our local joint strategic needs assessments. We had a lot. We had stakeholder meetings, and the public were invited. And we've had the hub within Ludlow, which is at the Youth Centre. We've had open days, and we plan to have a couple more going forward. So there's a lot of involvement going on in Shropshire, or in Shrewsbury. It's the same thing with regard to involving local people in the conversation and in highly. So, like I said, every time we have to put something on, we ask people what their experience was, what we've done, and what else they would like to see in that area. And we have had different focuses on different areas, as explained earlier, partly because Highley, for example, was our first place plan area, and it is the most at risk in the whole of the county for the cost of living crisis. So Highley is an area of need, like North Shrewsbury, like other areas. And actually, they had a pressing issue at the time, which was GP services, which they were about to have none. So there was a whole focus on that for a time, and that has proved really fruitful, actually, and it's a model that we'd like to replicate elsewhere. And the involvement with the community there was constant. We were constantly talking to the community. We had open events, we had surveys, we had meetings, we had discussions, and that's the approach we've been taking everywhere. So we have actually delivered against that and continue to deliver against involvement of local people, as far as I'm concerned. With regard to women's health, we know that nationally this is a massive issue, and there's a national strategy. And for this last year, there was funding, came across 2 years of funding, some of which we've been able to target with this, but we don't know about the sustainability of that funding. And so what we have been doing, as I said, in particular on the women's health, is to focus on the training and development of our local clinicians and allied health professionals around, and partners. And skilling up, because actually that's where we're going to get some sustainability for very local areas to be able to deal with more complexity rather than just making a referral. It's not going to stop referrals. It's not going to, that we need the expertise of our consultants, absolutely the important part in our system, but where we can have people access the service close to home, then that's what we're aiming for, and that's what's being developed through our approach. With regard to mental health, our children and young people mental health service is currently going through a development. So the contract is coming to an end. It's been extended for the short time while we work collaboratively across the system to develop a new specification around children and young people's mental health. And we're in regular conversations around how we're embedding the mental health offer within our hubs. So that is ongoing. But we also recognise that mental health just isn't one thing, and it isn't about one provider. Having good mental health is about people feeling good in the communities where they are, but it actually has to have a focus across everything, and people being able to get into nature, all of those things impact. So there's a lot of work for us to do collectively to think about how we can really get into that preventative space with mental health, and there is more to do. So social prescribing is a huge fantastic offer that we've got locally that does support people with lower level mental health concerns, and then those routes through to keep people well, but then also to escalate need are there, but need more work, and we will be continuing to work on them. So thank you.
Thank you. Can I just come back in a second?
Please, yeah.
Yeah. Thank you, Penny. Much appreciate what you are doing, but it's obviously my job to demonstrate where there may be gaps in the service, and the facility on Meal Estate has one usable room, and so it's not going to be possible to have the same level of service in Meal Estate as it has in Highley. And indeed, that's not going to serve the whole of South Shrewsbury. So there needs to be a much bigger estate that's going to be used. And with regard to trying to optimise your use of resources, have you considered having a mobile service? You may remember that there were mobile vaccination centres in buses, and perhaps the same thing could apply to dental services, women's health services, and mental health services, so that you can move those around the county and optimise your use of resource.
Can I come back into it?
Please, I'm going to answer exactly the same question. I think mobile services is an answer to some of the problems.
Yeah, thank you. Yeah, totally agree. And I think just to point out that I think we need to go back to the premise of the hubs, that sometimes the hub working is a way of working and not just a place. So we also have in South Shrewsbury, there's also Louise House, which is absolutely has a huge amount of offering, particularly around SEND and Autism Hub is there. And it's well accessed by the community and really well utilized. And it is sort of a stone's throw. It is there. It's in South Shrewsbury. So I think for us, we also have to think about, yes, we've got a partnership developing with Homes Plus and the way of working where we can utilise that estate to best effect and have an offer in that area that needs that specific offer, and that's fantastic. But we also need to think about how are we routing people through to the other very local offers. Louise House is only around the corner, or maybe how do we then use the community building that's on the other side of the Meal Estate, potentially, if that's where we need to go. So we need to just think about what we've got and how we can use those to best effect. But totally agree. And then the mobile offers, absolutely, we are thinking about how we are continuing to use our hub. We have a mobile hub that goes into farmers markets, for example. We're continuing to use that in a way that is helping people access it. So they do blood pressure, they using that mobile offer. We're doing mini health checks and health checks, which include point of care testing. So all of that is currently happening. With that, I would just say we're reliant to be able to do that. We're reliant on grant funding. And it does come down to that sometimes at the end of the day. So we really need to just use our resources best effect and be able to apply. So we applied for grant funding to be able to, we got it, we're using it. We're going to do the same next year. We're doing as much as we can to create those offers. Thank you.
Thank you, Rachel.
Yeah, it's just a bit on Penny's. I mean, I think I said at the start, this is a really ambitious programme. We want, we absolutely believe in it. The outcomes are showing, speaking for themselves, that this is the right thing to do in a county, particularly such as Shropshire, with over a huge area with access issues. And actually it's about integrating all of that from prevention, inequalities, all of these elements. It's very ambitious, and I think it's great that what I'm hearing is that everybody's sharing that ambition. And I think, as you said, identifying gaps, including that in our programme going forward. But all of that does come, and I think as Penny said, we've got to manage that and prioritise that constantly, go with where we've got the opportunities. We are every single partner involved in this is in a difficult climate. We do not get some of the funding coming through, but when we get them, we jump on them. As Penny said, when we didn't get the national funding, we didn't sit back. We went straight back and said, this is absolutely the heart of what we do in rural areas. We had a meeting with NHS England last year where we were asked about particular pathways, and we said, actually, for us, this is the solution, because you can wrap all your different pathways, your clinical up in community. This is and actually, because it is in the 10-year plan, so that gives us, but we're not getting. So there's the pathway is there. We continue to challenge with cost of living. Again, we said, actually, this doesn't recognise the increased pressure on rural areas once you get into this, and with low wages and all of that. So I think we're all really ambitious around this, and this is being done within the resources that we've got, which takes more time from a capacity point of view, because actually these are really complex when you have to knit together something differently in each area. I think previously people have tried to go in and do things with a particular view on it or a particular way. That doesn't work. You have to work with individuals and communities and build that around. So so I guess what I'm saying is that I get it's absolutely ambitious programme. It's fantastic to get the feedback to link all of this. It will be done and it is being delivered through partnerships. But just, we want to keep lobbying around that, but just to manage that expectation, we do continue to make the financial benefits by aligning resources. That's how we're trying to do this, so all those partners coming together. But we can't do anything either financially or capacity-wise, everything, so we are prioritising this. So it's just, anything we can give in terms of pushing that forward, make, landing the messages. But for us, it was start this journey because it's the right thing to do. Some of those, you can start to see that coming through. This is gaining momentum. People are coming along with us and we just want to keep that going, and it involves everybody. So just to give you some assurance that areas are not being, but we have to do this in a managed way. And it's brilliant work to try and knit this together because it's not easy.
Thank you. It sounds very exciting. Are we more dependent on the voluntary services to deliver some of these? Much more so that we coordinating that. Thank you. Heather.
Right. I will try to be a bit more strategic rather than looking at my own division. Yes. Bishop's Castle is, of course, not in my division, part of the southwest, and therefore I have a number of questions, but it is a bit more strategic. I think what you're trying to do is, as you know, I've been very supportive of for a very long time. I think the cross-border working is absolutely vital, and I'd be very interested to see where you get to with Welshpool Hospital because it provides so many services, including dialysis. And when I go to Welshpool to see the breast screening there, and I'm not allowed to use it, but apparently it turns up in Bishop's Castle, but I can't use that either because I'm not with a GP in Shropshire. There is some work that needs to be done so that we're not all travelling all around the world just for me to go and block a space in Shrewsbury, at the Royal Shrewsbury. So thank you, and I wish you great luck in improving all of that through the Marches Partnership. And Knighton, again, is important. But the Palace Teaching Health Board, I think, has come a long way, but needs to come a bit further.
Some pragmatism.
Absolutely. Great. What I would also be interested in, you're delivering many of these things and building on those in many places. How do you measure those outcomes, and what have you learned that you need to do differently various places, because that needs to be used when you embed in other places? So I'm also interested in, you seem to be delivering these services from the youth centre in Ludlow. How sure are we that Ludlow Youth Centre is going to continue to be there, you to continue to deliver through that? Because I know that there have been issues around that and the fact that Shropshire Council owns the building and may be wanting to sell it. So then where do you go? And is that when you begin to work with Ludlow Hospital to do more on site there? Because what also leaps out at me is most of these hubs that you put in may work really well where you're doing them, but actually we don't seem to be using Shropcom much. And so I'm interested in why that relationship isn't there, so that actually we begin to underpin those community hospitals too. Because in some places, certainly in Bishop's Castle, it may be the place that we need to do that. So where am I? From the slides that I saw, the hubs seem to be open 1 till 4 or during the day. Do you have opening times in the evening for those people who are working, who need to be able to access those things, especially women looking at menopause and so on? A daytime drop-in is not going to be particularly helpful for those who are under stress at work and so on. Right. I'm really pleased that you're using the rural proofing toolkit. I would like to see the outcomes. I know we do because I ask all the time, but I'd like to see the outcomes from this ICB from time to time, just to see what you're picking up from it. And all of that work that went into the SNAs was so good. And my next question is, how do you make sure that all your partners actually understand what rural proofing is and are actually signed up to that? Because that was one of those concerns that Jeff and I had, that some of us would be signed up, but not everybody. And then I look at the priorities in the paper, and priority 1 is access. But this access is only looking at a well understood front door, access to information and advice, and focuses on self-care. That's brilliant. Absolutely what we need in the building, but it's the access across the whole system that's the most important thing. And you will have seen, or you may not have seen, huge swathes of the southwest are having huge problems with broadband, so they don't have access. But even when they are paying for broadband, they don't have access to reliable broadband, and some of those it means they don't have access to a reliable landline either, because they're getting their landline through their broadband. And on top of that, they have no mobile phone signal. So rural proofing is now beginning to be stressed because of the input. And Shropshire Council did a whole presentation on IT and how we're going to be doing everything on landline and getting everything online. And it cuts out huge swathes of the population at the moment. So I don't want to see us in health across the board forgetting that there are so many people who can't access this. And it is a low wage area, certainly in most of the rural areas. Although, as we saw in the rural proofing paper, that it looks as though we're all wealthy because we've got all of these socially active people who've moved in with money, there's a massive layer underneath that who are not and are disabled from many of these things that we're now trying to do. It is the future. It's just that the integration of that is going to take time, which brings me to my last bit, which is, well, it's 2 bits actually. A time frame. Eve, I know it's difficult because funding is so very scarce. But actually, communities need some sort of hope. Even if it's in 2 years' time, they need to have something and a bit of a communication when they're having so much trouble just accessing the Royal Shrewsbury site or any of these things. They just need some communication about when things are likely to improve for them and how. And I love this how can we help idea. That is a huge cultural shift for everybody. How are you going to embed that? I think that's everything. Sorry.
Please, you're going to respond.
Should I start? I don't think I'll be able to do all of it. Okay. Measuring, we are developing a dashboard that includes all of the list of metrics that we put up. So we are taking the activity data. So what additional things are we doing? And we're monitoring that. And then we're also monitoring how things are changing on the outcome side. So are we reducing the number of children who are not in education and training? Are we reducing the number of assessments for children's social care? Are we reducing the number of non-accidental injuries or accidental injuries for children, young people or adults? And are we? So all of that list. So that dashboard is in development. And I think we alluded to it in the paper, but we're seeing some real green shoots on that. So there is an increase in activity, and it does feel like with what we've looked at so far, there is something that we can't say yes yet, and our social care colleagues have gone, can't publish anymore. This is all you can say. Things are reducing, so that, I mean, it's really positive. But we need to look at that more and have a whole year's data rather than just 3 quarters to kind of understand. The learning, we're absolutely taking the learning across everything. So you said it just now, and one of the biggest things is when we're developing multidisciplinary teams, whether that's being the care planning forms of mental health, the integrated practitioner teams, or the proactive care, it takes time. People have worked in a particular way, and I dare say in a very siloed way for a long time, and actually working collaboratively to sort of do things a little bit differently and stick your head above the parapet and say, oh, well, let's work over here and do it. It just takes time. And we do get there. And we've seen that with the integrated practitioner team, the care planning forums, but it does take time. But we are, so we're taking the learning, and through the SHIP subgroup, we're sharing the learning on a regular basis across the different paths of development. There'll be more there, but that was just what came to mind. Ludlow Youth Centre is a continuing conversation. We are very keen as a programme that is the right space. It sits in a larger piece of work for the local authority to figure out. But I think that's all I can say.
Yeah, I mean, I think the only thing I was going to comment, because you asked a question, I think one of Councillor Benedict did as well, about estates generally, and I think Councillor Allen, you mentioned libraries. That's why it all has to be joined up, because these will change. We have to rationalise estates, not just in Shropshire Council, but make sure we're using best use of estates across the voluntary sector, which you mentioned. Some of these aren't going to be based in Shropshire Council or NHS premises. They have to be in community venues. These are constantly changing, as everybody said. So the point is that having the joined up conversations earlier on, being clear what the priorities are and use what each service needs from those centres, and then aligning those. So it will continue to evolve and change, but those conversations are absolutely happening. We're committed that we need hubs within these localities, and so we'll continue to work with communities around that in each area.
Can I come back on that? Certainly in Ludlow, there's also one of the most deprived wards in the West Midlands. And where you have established something, if you then move it, you lose a lot.
Yeah.
From that. So actually building those risks into that are going to be very important in making sure that this is maintained and works properly for the future.
And it's why we're working really hard on that at the moment. Totally agree. And the location in Ludlow is all about its proximity to the most deprived area, but also its proximity to town. It's in between, isn't it? And it's where it should be, in my view.
Which was my point. Really.
Yeah, but we'll add your endorsement to that then, Helen.
Let's do
it. Shropcom.
Shall I pick that bit up?
Yeah.
So just on the Ludlow bit, absolutely want to develop the services within Ludlow Hospital and look at what the other opportunities are. The challenge we have is because the ICB doesn't own the estate, it's NHS Property Services. I don't know whether you can minute an eye roll, but it does make it more challenging, and actually it's, it takes too long. I think I'm going to be picking up the card for the Ludlow issue around the hubs. I don't know if that's a good or a bad thing, but I do have skin in the game because, as you know, my family live in Ludlow, so that is a bit of a conflict. The community services, they have been working with us and developing some of the initial MDT work that we've been doing through some of the community and family hubs, and certainly through some of the public health nursing and so on and so forth. Again, pretty fresh off the press. We've had some recent conversations about how we start and look at the art of the possible with district nursing services, some of those adult services, therapy services, and what that should look like, working through the hubs and through the primary care networks to ease that access. So can we do more wound care, etc.? That means doing a piece of work with commission services that we do for general practice, which we're also starting. So a lot of these things are highly complex, but we're trying to align them so we can work within the envelope of finance that we've got with the people that we've got. Actually, can we do something because of the challenges that we face around that? So Shropcom are absolutely at the table, and they're certainly involved in the end-to-end pathway work. I know your cynicism, but we can have a conversation about that. We're really lucky with our new Chief Medical Officer that she's really starting to bring that kind of clinical work together, and population health, the integration work, the neighbourhood work is a real focus for her. So she and I are working on that and making some really good progress. So that's really good. We do need that investment, but how we get that investment in the challenging environment we've got is really tricky. But we've had some different conversations with the community services. So that's really helpful. And all of this will eventually have an effect. So measuring those outcomes, that evaluation, that learning, will eventually, not immediately, but start to have an impact on our urgent care system, and how we look at when we're doing proactive care. I'm really interested in those lower levels, my age, when I retire, keeping people well, managing long-term conditions, stopping people from getting them in the first place, and what are the services that we need to wrap around that, whilst also managing the complex frailty issues that we have at the moment, and then obviously managing the planned care waiting lists as well. So none of this is easy, but community services are in the tent, and we're now having that discussion about how do we layer on those community services onto this work. They're in there, but in a more effective way.
I'm really glad that they're now in the tent. I would
With
be.
me.
I will be very interested to see what that actually means, because for a very long time they have not understood access. They have not understood a whole range of issues for the very rural areas, and they thought that Ludlow for us was access with no public transport, and Ludlow has its own hinterland, but for us it's not it. And so if you are modifying their approach, I'm really grateful. I think I'll leave that. I think Rachel was about to come in.
Good, thank you.
It was just to pick up a couple of points. I mean, I think absolutely well made around the digital, and just to give a bit of kind of digital and the kind of mainstream around culture, because completely agree. These are not things you can do slowly. So from a Shropshire Council point of view, this the neighbourhood working part of the programme sits within the customer journey alongside the digital, because actually you can't do one or the other. The two absolutely overlap. They're linked together. It's not just about complex care, it's about the prevention. And actually with people in hubs, you can support people to get online for the things they can get online or get access. But for those who can't, then you've got that offer there. And that's why we're so keen that, given the profile of Shropshire, that the two actually overlap. They don't sit in isolation, and that might not be the same in other areas. Some areas have much more ability to get online, either because technically or for other reasons, but that isn't the case in Shropshire. That's one of the reasons, whilst this is a system-wide piece of work, it sits across the system. For us, we want to embed that in the customer journey. As part of that as well, there's a piece of work around digital exclusion that's also part of that. Actually, David Baker's just been chairing the meeting with partners this morning, recognising some of that challenges. And the other bit is culture change. And again, there's got to be a whole programme of work around that. Again, some of it sits in the system. The AAA's Ask, Assist and Act, that's been developed collaboratively, but then there's a whole piece of work to do as a council to embed that in our new operating model and organisational development, to make sure that it's absolutely embedded, it's not an add-on. How do we help is why we're here. So that's, again, a bigger piece of work, but that's just to sort of give context of why that sits there and is so important. And then the other bit, which we haven't developed as much, Penny touched on it, but is really critical and is the outreach offer. So whether that be buses, that pop-ups, that's working wherever people are, continuing to build that. We've focused more, there's some parts of that, we've mentioned the farming community and others, but actually the ambition is to align that much more to some of our other outreach offers that we've got. How do you embed that? And that's, again, if I'm honest, it's around capacity. We want to again, what does that look like? But it all fits together. But from a Shropshire Council perspective, a lot fits under the customer programme, which, whilst digital is part of that, there's absolutely recognition that digital isn't the solution for everything, or can't be the solution. And that's why some of this has to happen in together. And we push back very strongly. It might work in Birmingham or other areas, it doesn't. That Shropshire is very different. So just to give that kind of wider strategic context. And I think as we go forward again, you might we're really interested in the feedback, how we continue to develop that, but also can share more outputs around those elements and how that's working in practice, particularly things like the cultural piece. We're just kind of starting that now, and it's built on what we did in COVID, some of it, that really different, and how do you actually embed it? We did it then, but how do we make that mainstream going forward? That's why we're here, after all.
But you're going to respond quickly. We're running out of time. I've got more questions to ask, and I think we could spend all day on this because it's so interesting. So I'd love to get on. So Please respond quickly.
So it's around opening times.
So we need to just focus on the needs of the community. And if so, for example, the menopause work, those sessions have been in the evening, exactly as you say, they're working age. So we're recognising that it isn't necessarily that the only time, and some of the GPs in Ludlow, for example, are telling us actually I've got quite a working age population that needs some support in X, Y, and Z. So can we do it later in the day when we're talking about having open access clinics and things like that? So those conversations are there. The idea that it isn't just during the day is there, but it will be directed by the needs of the community and resources. You know, we'll do our best. Yeah.
Thank you. Councillor Bartley and then Councillor Mosley, and I think we need to sort of wind up because we've got 12 minutes left or thereabouts or whatever. But thank you. Thank you, Nick.
Thank you, Chair. First of all, thank you very much. I'm Deputy Cabinet Member for Children's Services. Very pleased to see all the work you're doing there. There wasn't a great deal of mention of services for the elderly. And I think I'm right in saying that Shropshire has a pretty high proportion of elderly residents, likely to increase rather than decrease. I represent Brighton and Bashchurch, which are just a bit north of Shrewsbury. And to just go back to the question that Councillor Bernie Benting asked initially, I think a lot of elderly care that isn't being given at the moment through the established networks and so on, people end up in A&E when perhaps if the sort of services you're talking about had been available through the GP or with one of your hubs, the fall or whatever it is that has put them into A&E might have been avoided. And there wasn't much mention either of GP services. Now, in my area, there is one medium-sized rural GP practice in Bashchurch. It's already in a building that's far too small. And frankly, the prospect of finding funding for an enlarged GP building is looking pretty big ask, and isn't likely to happen anytime soon. And in the meanwhile, the GPs are saying, well, we could offer additional GP sessions, but we literally don't have the room. You know, we've got 2 half days in the week. Well, you know, who wants to come for 2 half days a week? You know, they need a bigger building. And there's been a bigger building, or the need for a bigger building, identified for maybe 15 years, something like that. There is a site earmarked, but and I don't need to say to you, we're trying also to deal with NHS property services, and you know, it's all extremely hard work. So in the meanwhile, you know, what can you do? Because people can't get a GP appointment, or at least they can't get one quickly. So if they're frail, they've had a fall, as I say, maybe it doesn't justify going to A&E, but A&E's pretty close in Bashchurch, so you go there and you just add to the problem that Bernie Bentic was talking about. Sorry.
Thank you. So yes, I think what you're talking about there is whole system kind of shifting that's needed, and there is a lot of conversation going on about how we do that. With regard to adult offer, the development, this work absolutely is an all age piece of work. I mean, Claire will come in on the frailty bit in a minute, but just to say, from a kind of developing the multidisciplinary approach, we've been absolutely working with GPs through primary care networks. So they've been working with primary care networks has been absolutely fantastic, because, you know, whatever you want to say about them, it's a collection of GPs coming together, and actually there's a focus to be able to do that collaborative working rather than trying individual GPs in a patch. So it's for us and developing this way of working. Primary care networks have been amazing. With regard to the offer, we have been connecting with those things that are already in action, because there's a wealth of voluntary sector offer and library offer and different things that are going on that do, from a very preventative way, really do support people, older people as well as younger people. They're there, but it is building. And then from a social care perspective, we're looking at how we can, because I'm learning that each area of Shropshire is very different, presenting needs to social care. So we're actually trying to understand that and then look at how can we put in a more through the hubs and that joint working, a much more preventative offer to stop people showing it, because in some areas of Shropshire, I understand people come in and they're very complex. They're not known to us, and then they just arrive and they're very complex. And actually, how can we shift that? So we're connecting with people much earlier, so that slows down, that stops. But the same thing for A&E. So if people are not getting what they need, and then move into crisis. So all of this is about all the work that we're doing is about reducing that need and that crisis, people tipping into crisis. So it is there. We did start, just to say, it probably feels a bit slower on the adult side because we did start with the children and family focus, but it is absolutely all age and it is building. So that's where we're at, and working with the voluntary sector.
Yeah, and just to say, some of the hubs have got dementia services that are starting to develop, so dementia cafes and what have you in them. So like highly. So you're absolutely right about the falls and the frailty issue. Those are the people that are turning up in A&E, and we know that if somebody has a fall and ends up being admitted into hospital, that their outcomes when they come out are not as good. So we are developing. There's a number of programmes through the voluntary and community sector, like Energise, that run falls prevention, exercise programmes, all of those kind of things. We're trying to develop those across the offer for all the hubs. There's something about that loneliness and connecting people within those communities as well. The dementia services, the dementia vision, and building that into frailty, because dementia isn't something on its own that sits in mental health. It very much, we think, fits into that ageing well programme rather than frailty. There's a whole strategy that's been developed by we jointly funded a public health consultant to come in and do some work on that frailty strategy. And we've got a project that we're just about to launch, again, based on that sort of risk, population need, and so on and so forth. So we will be developing that offer in the next 12 to 18 months. Services will start to improve in the next 12 to 18 months, but it will be a longer term plan. None of these things happen very, very quickly, unfortunately. GP access, probably really complex GP premises, as you know. I mean, that's even more complicated than just looking at things like community hospital sites, acute hospital sites, because the GPs obviously have a financial investment into their own premises as well. So that starts to become very, very tricky. There's a whole recovery programme around access into GP services. And I think GP practices are slightly different than the primary care networks. So what we're trying to do is work with the primary care networks, the groups of practices, to deliver those services. And we have a rural PCN. Pretty sure Baschurch and Brighton fits into the rural PCN, which goes out to Westbury, and there's some around sort of the south west bit, as well as so Minsterley, Ponsbury. I've been living in Shropshire quite a long time. I know where all these places are now. So actually, how we work with that piece is different, because we're thinking about that kind of rural proofing piece and how we deliver services across the rural primary care network. And again, that needs a bit of development and work, but they're working really, really closely with us. The primary care services and the community services are absolutely critical to the delivery of this neighbourhood work, but we can't do every clinical area straight away, which is why we're focusing on diabetes, frailty, and then doing cardiovascular sort of later this year. because I think we've got to be really honest. Diabetes is going to take 2 to 3 years to embed. It hasn't been looked at for a long time. The outcomes are poor. We know that. So we've got to have a different approach. So that's kind of the first thing we're tackling.
Chair, can I come back very quickly?
Very quick.
I've read through some of the strategy documents coming from the Shrewsbury Primary Care Network. And of course, there are, taking my local hat off, there are greater priorities within the town in terms of dealing with GP premises within the town than there are in the more rural areas. And I get that. And the problem with the Shrewsbury Primary Care Network is, of course, they're going to give priorities to the most pressing problems, which means that the more rural GP practices are way down on the waiting list. And what's going to happen in the meanwhile? And again, politics aside, with the government's house building programme, I mean, a massive increase in the number of houses being built year on year on year. Where are these people going to go for GP services? Forgive me, and I'm not sure we're getting the answers from the government that we should be getting. Because you shouldn't be building another 2,000 houses every single year in Shropshire and think, oh, well, they can use existing GP services, they can use existing schools and so on. So, anyway, I do think we all need to lobby pretty hard.
Thank you. Pam Mosley.
No time at all. Anyway, I'll try to be very brief. I'd like to echo my thoughts about welcoming this service. I think every area of Shropshire would like one of these hubs. That's not possible. They sound really good and effective. It's about funding, really. I mean, throughout the report, there's reference to it being very challenging on funding, and most of the savings that have been made so far have been about combining resources, using estate we already have, etc. And we know that the voluntary service sector are also struggling, and we know what state the finances are here. How vulnerable is this programme to lack of funds? Not just rolling out what we've got, but rolling stuff back. I mean, if services have to cease or have extended life, or some things withdrawn, this isn't going to happen as we all like it. So how vulnerable do you feel on that? Then a couple of quick questions. Is Sunflower House in Shrewsbury, do you have posters? I've got 2 notice boards. I'd love to advertise the service. Do you have something as?
Yeah.
Could you forward those to forward them to other Shrewsbury councillors? And then there's a small reference in the report to services for migrant and refugee women. Could you say a little bit about that, because it's only very tangentially mentioned in the report? Yeah, thank you.
I mean, I think just to flag, as we have in the conversation, finances is really challenging. I think we're asked to flag that as a risk. We absolutely know it's a risk, which is why we flagged it continuously. We have so far done this but without additional funding. It's basically, as you said, aligning funding that comes through various routes. There is risks in all of this. You've mentioned estates. There's always going to be a problem in terms of and I don't mean just Shropshire Council, I mean just generally facilities, staffing and capacity to manage this, but which is why the model is looking very much at doing this in a the pace is at the pace it is, because we have to manage that within the resources we've got. And we're looking at sustainable models wherever we can. So we've said that around, for example, women's hubs. It's about trying to sustain that. The Act Assist and Act, the culture change is again about sustaining that in a way of working going forward. So absolutely recognise the risk in terms of this. We're looking at opportunities around additional funding all the time, and obviously I think with the new 10-year plan that gives us an opportunity around neighbourhood working, and we're set up ready to go and already looking at opportunities to raise awareness around the work that we are doing locally, but the need for that to continue. So yes, it absolutely is a risk, but we are have always worked in this way around with limited resources. We do that as organisations very well, and we always do that as public health. So, that's the way we, but this is the right way to move forward, as I said, to flagging the risk. Basically, the voluntary sector, again, you know, they are so important in Shropshire. It's something we pick up as a health and wellbeing board, has picked up in the prevention strategy again, looking at ways that we can collectively ensure that we've got that strong infrastructure and support, particularly coming out of that over the last few years. We know that there are real risks there. It's again, how do we work together collectively to recognise that invaluable role, and part of this way of working is showing that we're all partners equal. It's not about one organisation. There is efficiencies in the model that we're creating by aligning and not having duplicate services. That doesn't give you the reassurance, but what it says is there's an opportunity. We've continued to work like this. We're building that. We're building from a way of working without that funding. We're looking at sustainable funding. Any support we can have to continue to share how this model is working is really, but we're committed to it. As we've demonstrated, it's embedded in our operating models. It's embedded in our strategy as an integrated care system. It's just perhaps not happening at the pace we would want it to. Next.
Good, thank you. We are.
And the migrant and refugee.
We're out of time now.
Do you want me to quickly come back on?
Go on.
So there's a couple of key areas where that work is coming through. The women's health and inequalities work is one of them. So working very much with different communities, the Bulgarian community, the Muslim community in Craven Arms, and the migrant community. And the other area where it's really strongly felt is trauma. So we're looking at trauma-informed approaches, and in particular how that, particularly refugees and migrants that have recently arrived, and the impact of that, and then the sharing and the learning across all of those. So whilst we may learn about women's health, but we also then will be sharing and learning about working with those communities across the whole element. And I would just say that a lot of the work that we're doing now has been informed by what happened in COVID, where we recognised that there were communities in Shropshire that weren't necessarily previously recognised by a lot of people. They were by some, obviously, but not others. So we have a really big Bulgarian community, as an example, in Oswestry area. And so it's around making sure that when we're developing health and care and wellbeing and services, that we're taking into account different approaches of different communities and different understandings of different communities. That's absolutely part and parcel of the way we're developing them.
Good. Can I thank Annie and Claire for coming, and please come again. I found today extremely interesting. There's a hell of a lot going on, more than we realise, and I don't think it's publicised enough, to be very honest, exactly what we are doing. And I'd like to suggest we do that. I'd already written down to mention about the local plan and 1,500, 2,000 new houses a year, as Councillor Barclay's just mentioned. We should be working with a local plan, I think, and planners to look at how we can fund some of these projects from those developments, those developers, because they are affecting those communities. The communities are constantly changing, the demands are constantly changing, and I think those are the people, if they want to build houses in a community, they should be partly responsible for funding how that community operates. And I'd like to try and move that on with planners, that we actually do together with local plan work together, because funding for surgeries, doctors and so on should be in that local plan, but also for local community services. I don't know if they are or they're not, but it's something that we need to look at, I think, in the future, because it's really down to developers who are changing our society to finance it.
And use Oswestry as an example.
Yeah. Good. Okay. Thank you very much indeed, ladies, for what you've done, and please come again. It is very, very interesting, and keep us updated, please.
Thank you.
Thank you.
Thank you.
Item 10, update from the Joint Health Overview and Scrutiny Committee.
Thank you. I'll just keep it brief because I'm conscious of time. But yes, the last meeting of the Joint Health Overview Scrutiny Committee took place in December, and invited officers from across the integrated care system to attend. So the committee were able to scrutinise and be assured of the progress being made to deliver the must and should do stipulated in the May SAT CQC report, specifically into the relation to the area of urgent and emergency care. It also looked at the related but separate item of winter preparedness. So there had been some working groups with staff, senior officers during the autumn, and based on this evidence and what they heard in the committee made 4 recommendations, which have been published, and I will separately email to you so you can see them, but they have been published as part of the joint cost minutes. The next meeting of the committee is being held on the 10th of February and will focus on the must and should do's again, but this time into the area of medical specifically, where again the committee will be scrutinising the progress made to deliver these. So that's a sort of brief overview of where the committee has been and where it's heading to next.
Thank you. And just to let you know, the committee has, or the chairs of the committee of Joint Hospital have written to local MPs, the Secretary of State, with a series of questions about what is going on at staff, what can be done, what should be done, and asking the Secretary of State to come and visit and help us move things forward. We've also written a letter about 64 care beds that should have been delivered in the hospital plan and have not yet been delivered, and we're trying to progress to make sure they are delivered in time for next winter. So there's a lot of work going on, work in progress. Anyway, we can update you on that later. Work program we've done. The work program didn't do.
Yeah, we're nearly there. So yeah, in terms of the work programme, normally at this time of the year, the committee will be looking forward to the next council. Obviously, with the election upcoming and seem to be entering the pre-election period, this won't happen in that way. So it's really that today's an opportunity. The planned work programme's already been circulated to the committee. Whether there was any particular items that the committee would want to flag to be able to take forward, be recommended to the future committee, because obviously, you know, that it will be their decision in terms of what they take up. But any key areas you felt that you'd want to highlight from the work that you've done?
Yes, Heather.
I think I mentioned earlier, I think along with the hub working and so on, it would be really good for a future HOSC to look at community hospitals and how they're delivering and the way that actually they take part in all of this. Whether it's, I mean, we have a whole range of them, and I met Peggy outside who was concerned about renal
and virtual wards, wasn't it?
Yes. So there, it's across all the hospitals we ought to look at. But we've had a question today about Ludlow Hospital, and I was sent a question by a normal member of this board, which was around how those services in Ludlow Hospital are going to be delivered in the future, because she had been told that it was possible that those services, those beds in Ludlow Hospital will be overseen in future, not by a GP, but by an AMP or an ACP. And she's not, she says in her email, being derogatory about their skills, but actually it's not the same as having a doctor on site. So there are all those things that maybe we can look at from May onwards.
Yeah, thank you. So we have identified all sorts of things to carry on looking at. I'm terribly sorry. I know it's an exciting meeting. We've run out of time, unfortunately, and I do apologise. It's down to me for not managing it quicker. Can I thank you all for coming, and I did find that interesting. I hope you did as well.
That's great.
So thank you, everybody. Meeting is now closed.
Mr. Chair.